Welcome to this explainer. Today, we're diving straight into a giant puzzle that touches every single one of us, the incredibly complex evolution of the US healthcare system. It can honestly feel pretty unsolvable sometimes. But by mapping out exactly how we got here, we can actually start to understand where we're going. So, let's jump right in.
Okay, here is our roadmap for today. We'll be covering 1. A century of reform, 2. The four major actors, 3. The era of mega-consolidation, 4. The digital health revolution, and 5. Health in all policies. Starting off with Section 1, a century of reform. Basically, 100 years of arguing over who pays. Now, you might be thinking the debate over national health insurance is a sudden modern issue. Actually, guarantees for care have incrementally evolved over 6 major periods of intense political activity. We're talking all the way from the AOL plan back in the 1910s through the monumental shifts in 1965 when Medicare and Medicaid were created to cover the elderly and some low-income groups, right up to the massive shifts of the Affordable Care Act in 2010. To really grasp why these historical reforms were so controversial, you've got to understand that almost all proposals rely on a mixture of 3 main financing models. It boils down to this: who collects the money and who enforces the coverage? Is it government financed, where public funds pay directly? Is it an employer mandate, where the government forces your boss to buy you a private policy? Or is it an individual mandate, where you have to go out and buy your own coverage? So where does that leave us today? Well, we basically see a contrast between 2 major philosophies. On one side, you have the single-payer approach, which is entirely government-financed. It offers high simplicity and is totally de-linked from your job, replacing private insurers altogether. On the flip side, you have the ACA's pluralistic strategy. This model builds on what already exists. It preserves private insurers while using a mix of mandates and subsidies. And, this pluralistic approach is exactly what helped uninsured working individuals, like a single mother named Mandy Must, finally get subsidized private coverage when her employer didn't offer it. Moving right along to Section 2, the 4 major actors. Let's meet the players on the healthcare stage. Okay, so understanding the fundamental conflict in our healthcare system relies entirely on knowing these 4 distinct groups. You have the purchasers supplying the money, the insurers managing the risk, the providers actually delivering the care, and the suppliers manufacturing the drugs and tech. The inherent tension here is simple but profound. Purchasers want to reduce costs, while the healthcare industry, insurers, providers, and suppliers, wants to increase those dollars to maximize their own revenues. Let's rewind a bit to see how these actors used to interact. Back in the 1960s, a patient, let's call him Bert Neighbor, would have experienced a highly fragmented, really small-scale system. Independent hospitals and insurers maintain this very cooperative, highly profitable provider-insurer pact. Hospitals set generous rules of payment, and insurers basically paid the bills without asking too many questions, happily passing those costs right on to businesses during a booming post-war economy. Which brings us to Section 3, the era of mega-consolidation. Watch how the lines between those actors completely disappear. $69 billion. Let that number sink in for a second. That is the staggering amount pharmacy giant CVS paid to acquire Aetna, the nation's 3rd largest health insurer. We aren't just seeing hospitals buying other hospitals anymore. We are in an era of massive, trans-sector corporate oligopolies where one mega company controls multiple pieces of the puzzle. And here is the dark side of all that unchecked supplier power. Look at this shocking price jump for pyrimethamine, a generic drug that's been around for years. Going from $13.50 to $750. Unbelievable. It's largely driven by pharmaceutical consolidation and middlemen known as pharmacy benefit managers, or PBMs, who maximize their own profit spreads. So those distinct lines between our 4 actors, they've been completely erased through vertical cross-sector consolidation. You've got insurers buying up huge networks of clinics. You have providers buying insurers and suppliers. You even have non-health entities like Amazon and private equity firms jumping into the market. They're creating these dominant mega-corporations that literally control your healthcare journey from top to bottom. Faced with this hyper-consolidated corporate landscape, we end up with a really frustrating paradox. Massive excess for the wealthiest to consume the most care and stark deprivation for others. It begs a pivotal question for the future. Can modern data, artificial intelligence, and smarter public policy actually fix this paradox? Let's pivot to Section 4, the digital health revolution. We're shifting away from arguing over billing and toward predicting population health. To get what's happening now, you absolutely need to know this acronym. ECQMs, or Electronic Clinical Quality Measures. Basically, this is the new standard. Instead of just looking at whether a patient survived a procedure, modern practitioners use these real-time digital metrics to actively track and evaluate if care is equitable, high quality, and actually improving long-term outcomes. And just look at how the role of the modern doctor of nursing practice has radically evolved here. They aren't just clinical leaders at the bedside anymore, they are systems-level architects. They're utilizing predictive AI analytics to forecast which patients are on a trajectory to become highly ill and costly. They evaluate those ECQMs, scrutinize algorithms for bias, and use data from wearables to step in and allocate resources efficiently, way before a catastrophic acute intervention is ever needed. This quote perfectly captures the essence of this whole revolution. We are finally using advanced technology like hyperlocal electronic health record metadata and smartwatches to track and manage the social factors that actually make people sick in the first place. That leads us perfectly into Section 5, Health in All Policies. Let's look at building a healthier future across every sector. Okay, understanding this Health in All Policies framework, or HiAP, is absolutely crucial. It acknowledges a simple truth. True health is determined by city planning, transportation, zoning, and housing, not just what happens when you're sitting on an exam table. If we want healthier populations, non-health agencies need to be integrating health considerations into every single public policy decision. What a vibrant contrast to those sterile corporate mergers we talked about earlier. This represents what happens when local governments successfully integrate health goals into everyday community environments. You see walkability, green spaces, and active transport options. This is social determinants of health being prioritized in real life. Now, if you're a local health official wanting to make this happen, you don't have to guess. Nacho provides a fantastic, highly practical 6-step roadmap to start. You engage your champions, form a collaborative task force across different government sectors, get everyone on the exact same page about health equity, establish shared goals, understand your capacity, and finally, make a concrete plan. And the end goal? It's all about utilizing this framework to create dynamic, thriving neighborhoods that proactively manage population health. When we build communities like this, we're promoting daily wellness, which means way fewer people end up needing the incredibly expensive, highly consolidated acute care systems we analyzed earlier in this explainer. As we wrap up this explainer, I want to leave you with a pretty massive question. We are at a real crossroads in the United States. We know the history, we know who the powerful corporate actors are, and we see the incredible promise of digital health and cross-sector community planning. The question is, will we continue to let corporate mega-mergers define our health? Or will we leverage AI and cross-sector policies to finally conquer the paradox of excess and deprivation? Thank you so much for learning with me today. Keep asking great questions, and I'll catch you next time.